Hi, I am Dr. Reynaldo ROJoson, Director of the ROJoson PEP TALK. The title of my PEP TALK today is Patient Autonomy and Advance Directive. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. I launched this PEP Talk on May 15, 2021 with the module on COVID-19. The second module was entitled Patient Empowerment. The third module, Patient Management Process. I am now on my fourth module, which is entitled Rights in Patient Empowerment. What I have in mind in my PEP Talk, which may run for 3 years, is to empower at least 30 persons with my family members and my family and my patients as a priority. This is my key performance indicator. I hope you will be in my group of 30. The fourth module has 2 parts, basic rights and patient autonomy and advanced directives. Today I'll be talking on patient autonomy and advanced directive. I had the empowerment objective as for the lay people to have an understanding of patient autonomy and advanced healthcare directive as rights in patient empowerment. The foremost right in patient empowerment is patient autonomy. Patient autonomy is defined as the right of all competent adults to make informed decisions about their health and medical care. Patient autonomy is one of the principal ethical principles established in the medical world and being respected by all physicians. Patient autonomy is also embodied in the Bill of Human Rights, specifically on the right to health. Right to health means the states or countries have the legal obligation to promote the health of their citizens. And under the right to health, there are 2 components, freedom and entitlement. The freedom component has emphatically stressed that rights of every citizen to control one's health and body. Thus, patient autonomy is embodied in this freedom component of the right to health. So everybody, physicians or healthcare providers, and even relatives included, should respect patient autonomy with regards to decisions on health. In medical practice, the principle of patient autonomy underlies the requirement to seek the consent or informed agreement of the patient before any investigation or treatment takes place. However, this principle comes into prominence when hard decisions involving patient autonomy have to be made in the care of terminally ill patients. The Advanced Healthcare Directive will demonstrate the application of patient autonomy. There are 2 keywords or phrases in the definition of patient autonomy: competent adults and informed decisions. Competent adults mean conscious, coherent, and discerning adults. Informed decisions mean a permission or no permission is granted by the competent adults after proper understanding of the purpose, options with benefits, risk, cost, and availability data analysis, and consequences of the procedure to be undertaken. These 2 components or requirements must be fulfilled for patient autonomy to be ethically and legally binding. So after being advised properly and adequately, after studying more data and information by himself if needed, and after introspection, the patient can end up with a decision of either informed consent or informed refusal. Whatever be his decision, because of his right to patient autonomy. This should be respected as long as there is nothing illegal in the court of law of the land where he is residing. Patient autonomy should be respected in whatever settings, such as when being managed by a physician, when being managed by relatives, and when doing self-management. Let's now go to the Advance Healthcare Directive, or Advance Directive for short. An Advance Healthcare Directive is patient autonomy in action or in operation. An Advance Healthcare Directive or living will, the other term for Advance Healthcare Directive, is an advanced healthcare planning in which the author or the person who makes this explains how he wants medical decisions to be made in case he cannot make decisions already. By setting the contents of an Advanced Healthcare Directive, the author is exercising his right of patient autonomy as what are usually placed in the directive are, what the medical measures he will allow to be done, and what he does not want to be done to his body. By the way, a last will, as differentiated from a living will, is a document which the author or the person who makes this determines what and how he wants done with his property and other material things after he passes away. Advanced healthcare planning is not just about old age. At any age, a medical crisis could lead a person too ill to make his own healthcare decisions. So advanced healthcare planning can be and should be done in any adult age. Advanced healthcare planning is not yet very popular in the Philippines compared to other countries. If there are people making it, they are usually done by terminally ill patients who have accepted their status and who want to prepare well for the eventuality, not only for themselves, but also for the family. It is advisable, though, for all competent adults to have an advanced healthcare directive as part of the patient empowerment program to gain greater control over decisions and actions affecting their health. So it is advisable, as mentioned, that advanced healthcare planning should be done at any adult age. It does not have to be an old age or at the time when one is suffering from an incurable disease. An advanced healthcare directive is also included in an intentional living plan of a person who plans out his life properly. Expounding further, or to repeat, an advanced healthcare directive is a document that spells out some medical decisions and actions that the author wants done and not to be done to his body in case he cannot make decisions anymore. The document can be notarized or not. What is important is there is a concrete document that is known to be made, dated, and regularly updated by the competent adult author, and its contents are known to and accepted by immediate relatives and significant others. This document serves as a guide to the immediate relatives and significant others when the time comes to implement the contents, as well as to the healthcare professionals who may eventually be called to manage him. An example of an advanced healthcare directive, this is my advanced healthcare directive, which I formulated in 2006 when I was 57 years old, and have been reviewing and updating up to now, 2021, at age 72, which I have made known to my wife and 2 children. I will show you the details. The title of this document is Advanced Healthcare Directive on How I Want to Be Medically treated medically, when I am near end of life, when I have a terminal illness, and when I am bedridden. I, Reynaldo O. Joson, residing at being of sound mind, willfully and voluntarily make this advanced healthcare directive. If the situation occurs that I am in a vegetative state or coma from an incurable disease process or injury, as determined by two physicians approved by my wife, or in her absence, either by my son or my daughter, I desire and direct that all life-sustaining procedures and means be withheld or withdrawn, including assisted respiratory ventilation, artificially administered fluids or nutrition, like intravenous, gastric, jejunal, or other tube feedings, and blood transfusion, and that I be permitted to die naturally. If I should develop severe mental impairment to the degree that I am totally unable to perform activities of daily living, or at least to recognize and meaningfully communicate with my family and others, as determined by two physicians approved by my wife, or in her absence, either my son or my daughter, I do not want intensive or prolonged hospitalizations, major surgery, artificially administered fluids or nutrition, like intravenous, gastric, jejunal, or other tube feedings, blood transfusions, or assisted ventilations. If the circumstances or the circumstance occurs that I am in a state of near death, but a good possibility exists, more than 50% probability of recovery to a purposeful situation, such as my being able to write or otherwise communicate helpful thoughts and information to my family and others, then I do not restrict my physicians from exercising their skills with prudence, wisdom, and restraint. However, I do not desire extreme measures such as transplant, extensive and complicated surgery, chemotherapy, radiotherapy, dialysis, etc. And if the state of near death is part of a terminal cancer or other progressively incurable disease process or injury, then I desire that measures be directed at comfort rather than to delay the moment of death. Furthermore, if I am in a vegetative state or coma from an incurable disease process or injury, or in the state of near death with a progressively incurable disease or injury, or if I have developed severe mental impairment to the degree that I am totally unable to perform activities of daily living, or at least to recognize and meaningfully communicate with my family and others, as determined by two physicians approved by my wife, or in her absence, either my son or my daughter. And if my heart and lungs cease to function, I do not want to be brought back to life with medications or with electrical or mechanical ventilations or resuscitations, or even with ordinary cardiopulmonary resuscitations. In any of the above circumstances, it is my desire to be made comfortable with medications that are used to control pain, knowing that such medications may unintentionally hasten death. However, medication should not be used with intention of causing death. It is my desire that the cost of my terminal care be kept to a minimum, inclusive of diagnostic and treatment, and also place of care, minimalist management. Diagnosis should be mainly clinical, based on symptoms and signs. Unless there are compelling reasons to the contrary, I would prefer to spend my last days at home rather than in a hospital or other expensive medical facility, unless being at home would be an unreasonable burden on my family. This advanced healthcare directive shall be accompanied by implementing guidelines and instructions, which I shall make in due time and shall be read and followed by all concerned. I am legally competent to make this advanced healthcare directive, and I understand its full import. My wife, and in her absence, either my son or my daughter shall enforce this advanced healthcare directive. Witness my hand, this 20th day of January 2021, signed Dr. Reynaldo O. Joson. Here are the implementing guidelines and instructions. I, Reynaldo O. Joson, am a mortal human being who may get sick anytime of whatever cause. In the event that I became unconscious and cannot make any decision regarding treatment to be instituted on my body, here are the guidelines that I am leaving for my immediate family members, my brothers and sisters, and my attending physicians to follow. For diagnosis of my health problem, rely heavily on clinical parameters and include observation. Do paraclinical diagnostic procedures only when the results will significantly affect the plan of treatment. 3, try to save me only when my chances of recovery without disability, note without disability, are more than 50%. No heroic measures when my chances of recovery from my disease are less than 50%. No respirator, no nasogastric tube, no tracheostomy, no gastrostomy, no urinary catheter, no intravenous fluid, no blood transfusion, and keep me in the private room until I expire. No heroic measures if I have the following diseases or conditions: cancer, cerebrovascular accident. Do not hurt me unnecessarily when my chances of complete recovery are small. Let me die as peacefully as you can afford me. Keep cost of my terminal care to a minimum possible, inclusive of diagnostic and treatment, and also place of care. So as mentioned, advanced healthcare planning is not yet very popular in the Philippines. However, what is becoming more and more popular now is something akin to the advanced healthcare directives in persons who are seriously or terminally ill. The issue of withholding and withdrawing life-sustaining orders in the serious and terminally ill patients often crop up now in the last minute. In this day and age, if not all hospitals in the Philippines already have a ready pro-formal form, commonly called DNR order or form, with DNR denoting do not resuscitate. The DNR order should originate from the patients and significant others. They may arise after discussion with the physicians. The attending physicians of these seriously or terminally ill patients can make the formal medical orders only upon instructions from the patients and significant others. Patient and significant others should tell their attending physician way before how they want to be treated when they are seriously or terminally ill in terms of withholding or withdrawing life-sustaining treatment, which may be futile and which may affect their quality and dignity of life. If they don't tell their attending physicians beforehand, the latter, meaning the physician, will order all possible life-sustaining treatment despite the odds. The following have to be decided by the patients and significant others through an Advance Directive or DNR order, whether to withhold, meaning not to be done, to withdraw, meaning to remove after being done, whether to do resuscitation or not, whether to do defibrillation or not, whether to do intubation or not, whether to do mechanical ventilation or not, whether to do dialysis or not, whether to do nasogastric insertion or not, whether to do gastrostomy or enterostomy or not, whether to have artificial hydration or not, whether to have artificial nutrition or not, whether to have medications or not, whether to have diagnostic procedures or not, and whether to have operative procedures or not, and others. The patients and significant others can specify what to withhold and what and when to withdraw. All the above instructions from the patients and significant others should be written and signed and witnessed in the document or form. After giving the initial instructions, the patients and significant others can change or revoke them anytime they wish. However, this new instruction should also be written and signed and witnessed in a document or form. So this is an example of an advance directive. A short one: name, patient ID, birthday, address, religion, Roman Catholic, civil status, widow. The patient is currently in the state of dementia. The family members represented by her sons would like to have the following wishes for the patient. If she is already in a state of near death or unconscious and unlikely to become conscious again, do not attempt resuscitation, DNR, allow natural death, do not intubate, maximal medical care with no invasive procedure, comfort-focused treatment with medications to relieve pain and suffering rather than to delay the moment of death. But if there is a good possibility exists of recovery to a purposely situation wherein she can still communicate helpful thoughts to our family, then we do not restrict the attending physicians from exercising their skills with prudence, wisdom, and restraint. This is another short advance directive. I am so-and-so, a cancer patient. Should I be brought to the hospital during emergency or on my last breath, please do not intubate and do not resuscitate. Thank you. Sign the patient, the date. PS, I just need the oxygen. So there you are. Patient autonomy and advanced healthcare directive as rights in patient empowerment. Maximize your knowledge, kaalaman on these rights. Maximize your capability, kakayanan in seeking for and implementing these rights. And lastly, maximize your self-determination, kapangyarihan in using the rights and gaining greater control over decisions and actions affecting your health. With this, I end my PEP talk, which is entitled Patient Autonomy and Advance Directive. I hope I have empowered you to have a better understanding of patient autonomy and advanced healthcare directive as rights in patient empowerment. Thank you for your kind attention and good day, and mabuhay kayong lahat.